Okay, so looking a little more deeply at some forms, prevalence, and risk factors with non-suicidal self-injury. Forms of self-harm, and these are roughly in order from as you read them across the screen here. Cutting is cutting the skin. Carving tends to be deeper. Words, symbols, things like that into the skin. Burning, using fire, lighters, hot objects, erasers. Um, Biting, picking or interfering with wound healing, and inserting objects under the skin are all forms of self-harm that tend to involve the skin. Other forms of self-harm, punching or beating the self, head banging, hitting walls or other hard objects, having others cause pain, self-tattooing or piercing. Again, that would be doing that more for that pain sensation or to cause harm to the self and not for the aesthetic of it. Um, and then pulling out hair. Now, that would not be trichotillomania. Trichotillomania is more of a compulsive disorder, that kind of thing, rather than um, pulling out hair for the pain sensation to cause oneself pain. Right. So a lifetime prevalence of 13 to 17% in adolescents and young adults. And a lifetime prevalence would be the question that we ask in those situations, those surveys, is at any point in your life up to now, have you engaged in this behavior? And that comes in around 13 to 17%. Um, it, it appears to be more prevalent among female identified individuals. Um, in a 2022 sample or study, 13% among female identified individuals, 6% among male identified individuals. You will see numbers that converge a little bit more. That type of thing. So but in general, it's considered to be more prevalent among females. Risk factors associated with non-suicidal self-injury: presence of abuse. I think that's something that our minds tend to sort of go into, when we see somebody self-harming. Is this person a victim? Has this person been a victim of abuse? Sexual, physical, emotional, right? Neglect or parental indifference, family violence, particularly parental impulsive violence, relational factors, okay, separation and loss, poor quality of attachment with caregivers. We'll look at some research in a few minutes that might shed some light on that. Single parent households, and not in any way to criticize single parent households. I think that where that might come from as a risk factor is that single parents often find themselves struggling to have that quality of attachment. There may be a need to work more than one job to make ends meet, that type of thing. Parental illness, and parental mental illness. So all show up as risk factors. When we look at the individual person, we see risk factors associated with NSSI: emotional reactivity. So these youth tend to be more emotionally reactive in the sense that they react strongly with emotion. Emotional intensity. There tends to be an intensity about them, that they may feel emotion more intensely than others. Higher prevalence of feelings of hopelessness, isolation, loneliness, problems with anger, substance abuse, particularly alcohol and marijuana, higher occurrence of engaging in reckless and risk-taking behaviors, stronger prevalence of negative emotions. So, that might be one of those factors that sort of explains, why does your mind go to self-harm? Well, there's just a higher prevalence of those negative emotions, being in a negative sort of mindset. Social and problem-solving deficits. We'll look at some research in a minute that might shed some light on that as well. This is something I alluded to a minute ago. A study on parents and their interactions with their children, and parents of those engaging in NSSI, and this is more chronic NSSI, have been found to communicate the following in their interactions with their children. Invalidation and minimization. So they tend to invalidate the experiences of the young person. They may tend to minimize emotions, minimize the young person's feelings. Criticism, punishment. They tend to be more likely to take a punitive approach to their children, and distress. Okay, distress meaning, I think what we'll see in just a second here, where these parents allow conflict with their teens to become highly aversive, and they tend to de-escalate it much less than is normal. So they're allowing the emotional distress in the family to get to a very high level where we consider it highly aversive, and then they don't de-escalate these situations well. So if you imagine, interpersonal neurobiology, that line of thinking sort of teaches us that, neurons that fire together wire together. So if we grow up in a household where this conflict is allowed to get highly aversive and it's not de-escalated, our brains don't wire in such a way that we know how to de-escalate emotional situations. And I think that's some of what contributes to non-suicidal self-injury. And when we talk about treatment a little later in the day, we'll definitely address that in when we talk about treatment, in that a lot of what we are teaching is de-escalation skills, self-regulation skills. So that will come back up as we go through. Again, suggesting some interpersonal deficits. Now, this is not autism spectrum disorder, even though it bears some similarity to ASD. Research suggests the following in those engaging in NSSI: deficits in accurately reading emotional cues from others. Okay, so this may have a little more to do with emotional intelligence than with more purely neurodivergence in the sense of autism spectrum disorder, and then deficits in accurately conveying their own emotions through expression. So there's an emotional communication piece that may be missing with some of these youth. So again, when we talk about treatment in a little later, we want to make sure we're addressing those things. Comorbid diagnoses with NSSI. This is not an exhaustive list. It just has some of the disorders that we see comorbidity with non-suicidal self-injury: PTSD, post-traumatic stress disorder, depressive disorders, bipolar disorders, eating disorders, anxiety, and substance use disorders. So those are some of the things that we see frequently co-occurring with non-suicidal self-injury. I alluded to this slide earlier in that we would look at sort of the course of NSSI a little later. when we talked about it being a higher frequency occurring behavior. Um, the course of it. We'll talk about this diagram in a few minutes. NSSI can be conceptualized as a coping strategy, albeit a maladaptive one. It's not one we would prescribe for anybody. It can last for weeks, months, or years. And it tends to be cyclical rather than linear. And what we mean by that is that it tends to be to occur in cycles rather than having an onset and then stopping. It tends to recur. Okay, so what we see is that it can be triggered by stress. So a stressor comes along, the person discovers non-suicidal self-injury, they have an episode, they go into treatment, they go into a phase of recovery, another stressor comes along. Okay, another episode is triggered, they go in, they continue with treatment, there's a period of recovery, another stressor comes along. So it does tend to have that sort of cyclical nature to it, right?